In terms of your follow-up, Dr. Citardi, going back to our patient, you've seen the operate on the patient. When do they see you back? And then how do you follow these patients? Is it every like 3 weeks and then, 3 months type of thing
Yeah,
or
so the typical ground rule after sort of a conventional image-guided FES for nasal polyps is 2 visits in the first 2 to 3 weeks after surgery. And then at that second visit, I can get a sense of who's going to be a frequent flyer versus not. At that point, we start them on the steroid irrigations or exhalational delivery of fluticasone if the cavity is not crusty or dirty in a sense. If I think they're a frequent flyer, I'll bring them back in 2 months. If I think they're going to do okay, I'll say 3 to 4 months. But for the first couple years, most patients are coming back every 3 to 4 months for just routine checks. I encourage them to come back early, regularly during that early period, because they will feel great, but they could have a significant relapse and not have symptoms because the cavity's wide open. You only get symptoms when things kind of fill in to that extreme level again. So I encourage them to come back. And I tell them about that too, because it's an incentive then to tell like, even though you're feeling good, you got to stay on the irrigations. It's super important. And I'll use the analogy of like blood pressure medicine. Like when you take your blood pressure medicine, your blood pressure is good, but that doesn't mean you stop your blood pressure medicine. And that most people get that. I mean, if they don't, then, they're going to do whatever. But most people get that, but I do wanna see them early in that first year or 2 when they're doing well, because, if there's a smoldering infection, if they have cystic polyps, those are all things that we can intervene with in the office that I think prevents a progression to a full-blown symptomatic relapse.
And in patients who in that small population who are on a biologic because they're just had severe disease that wasn't controlled with topical steroids, are they coming in at the same frequency? Is there anything special or anything additional to think about in that group of patients?
No, I try to use the same frequency, basically. I mean, I try to be consistent. At that 2 or 2.5 year mark when they're doing well, I may start both groups, stretching them out to 6 months. I mean, the reality is there's a certain amount of attrition because people move. I also think over long periods of time, the disease process sort of burns itself out. Nobody ever really talks about that, but I think that certainly happens. If you have someone who has polyps at age 18, they don't have the same kind of polyps 20 years later. And those adult patients who develop polyps, their natural history is different, right? But we don't really have much information, that kind of longitudinal follow up.